I'm Dr. Diklu. Today I'm privileged to introduce to you Dr. Guohua Li. Dr. Li is a Finster Professor of Epidemiology and Anesthesiology and the founding director of the Center of Injury Epidemiology and Prevention. His research focuses on population-based, injury-related, and policy-oriented studies that encompass novel epidemiological designs, innovative statistical techniques, and complex data systems. Currently, Dr. Li is working on projects aimed at understanding and controlling the epidemic of drug overdose and drug driving, and uncovering the dynamics of injury risk and injury disease interactions during the process of aging. His areas of interest include developing practical tools for measuring and monitoring the safety and quality of anesthesia care, identifying and intervening on risk factors for major post-operative complications, and evaluating long-term effects of trauma and critical illness on cognitive functions and health outcomes. Dr. Li is a Guggenheim Fellow and a recipient of the Kenneth Rothman Epidemiology Prize and the John Paul Stack Award from Aerospace Medical Association. Without further ado, I present to you Dr. Li.
Oh, thank you. Good morning. Greetings from New York. Thank you very much for the kind introduction. I'm going to give an introduction to injury prevention, which has been my focus in the past 30 years. I don't have any conflict of interest to disclose. This is what I'm going to cover. Basically, I'm going to introduce some basic definitions and concepts, most basic ones in the field of injury prevention and epidemiology, and briefly talk about the issue of injury as a public health problem, and then I'll maybe discuss the prevention strategy, because in the field of injury epidemiology and prevention, we tend to focus on prevention. So what's injury? Injury is medically defined as the physical damage to body tissues and organs, resulting from the acute transfer of energy or by the sudden absence or blockage of oxygen or heat necessary for, say, the human body to function. This definition has a few keywords. I would say first, when we talk about injury, we're talking about physical damage or to human tissues and organs. So we're talking about damage to the human body. And then there is this etiological agent that's caused by the acute transfer of energy, which accounts for over 90% of injuries we're talking about. So what in the etiological agent of injury identified in the 1960s through many experimental studies and so on. I think it's a major breakthrough in injury epidemiology and prevention, because we know the etiological agent for the vast majority of injuries. We don't need to spend a lot of time and sort of effort to further identify the etiological factors, as in many other disease research. So we tend to focus on the prevention of injury or to intervene on the acute transfer of energy. Energy has 5 different forms: mechanical energy, thermal, electrical, chemical, and radiation. So this is what we're talking about when we say injury, morbidity, and mortality. And here are some data from the United States in 2017. Now it's 2021. The data have changed for some causes of injury, but overall the morbidity and mortality profile remains virtually the same. On the left side column, as mechanism say, we have unintentional injuries and intentional injuries, and also a small category of injuries with undetermined intent. So roughly speaking, about 2/3 of injury mortality are caused by unintentional injuries. Here I list a few major sources of mechanisms of unintentional injuries. In the United States, in the past decade, drug overdose has overtaken motor vehicle crashes as the #1 cause of unintentional injury and injury as a whole. And still, motor vehicle crashes result in over 40,000 fatalities each year in this country. So it's the second leading cause of unintentional injury mortality. And fourth, and so on. Definitely, it depends on age, sex, and so on. Fourth are the leading cause of injury mortality in older adults, and it remains so today. And then under the intentional injuries, we have suicide or self-harm and homicide or assaultive injuries. And also a small category of legal intervention, which involves death sentence or interactions between legal law enforcement and residents. So in the United States, every year there are over 6,000 deaths involving legal interventions or police shootings. In terms of the morbidity, the number is really staggering here. This is the annual number of injuries treated in emergency departments in the United States is over 30 million ED visits for injuries, and about 250,000 deaths from injuries, which account for about 70% of total mortality. And this is the well-known injury pyramid. Roughly speaking, when we talk about injury mortality, we're talking about really the tip of the iceberg, which accounts for only about 1%, less than 1% of the total injury morbidity. If we just look at injuries requiring medical attention or treated in the emergency department. And at the very bottom of the pyramid, injuries treated at home or not treated at all. No, we don't have any data on that or good data on that. There is a related term for trauma. And I think this training grant funded by the Fogarty International Program is called trauma risk training in low-income countries. So trauma is a very commonly used term, but could be very confusing. In medicine, when we talk about trauma, we refer to a subset of physical injury. So I'm talking about physical trauma, which is defined as severe injury, usually based on the injury severity score of 15 or higher. So we're referring a more severe injury that requires admissions to the hospital, and usually maybe to the trauma center. Trauma center here in the United States is part of some of the hospitals, sort of specialized care. So that's what trauma means in the clinical setting. But in the general public or in the society, actually trauma, the term trauma, maybe it's more used to refer damage to the mind or to the psyche. We call it psychological trauma or emotional trauma. Under that type is not treated in trauma center or usually in the emergency department. So maybe more severe psychological or emotional trauma might be treated by psychiatrists. As usually after exposure to some extremely distressing events, such as standardized experience, which 10 questions or 10 specific forms adverse events or experiences. That would be an example of psychological trauma. So physical trauma is treated in hospitals. It says my internet connection is not stable. I don't know if you can hear me well now.
I can hear you just fine, Dr. Li.
Okay. I'll maybe turn my
Video
screen. Yeah, so hopefully it will help a little bit. Okay. So trauma in hospitals or in medicine usually refers to physical trauma, but in the broad society, the term trauma usually refers to psychological trauma. But the two forms of trauma, I would say, are interrelated. Physical trauma could cause psychological trauma. In return, psychological trauma could also contribute to physical trauma. I listed a few examples here, like motor vehicle crashes or being involved in say a serious motor vehicle crash or in a gunshot wound could lead to PTSD. On the other hand, adverse childhood experiences could increase the risk of self-harm or depression could, so ACE is psychological trauma, and self-harm, say by cutting, by hitting, or by over, that could cause physical trauma. And some instances, such as physical abuse or sexual abuse, child abuse, cause both physical and psychological trauma. So child abuse in itself involves both physical and psychological trauma. And nowadays, I would say we are increasingly integrating the research and practice of preventing physical trauma and psychological trauma. And even though the two fields, say medicine and psychology, have largely operated separately, but in recent years, I think there is an increasing integration between the two. Is injury a disease? The short answer is no. Injury is not a disease, but the long answer is injury is a health problem, a major health problem, just like disease. And here, I would like to explain what are the relationships or differences between injury and disease. As you know, injury is included in the ICD code, the International Classification of Diseases, as a separate category of related health problems. But here, I think it's important to identify the differences between the two. First, the etiological agent. As I mentioned, the vast majority of injuries are caused by the acute transfer of energy. The etiological agent of disease depends on the type of disease. It could be genetic, could be environmental, could be behavioral, nutritional, and could be physiological and biological, such as infectious disease. That could be. So the epidemiological agents are much more complex for diseases. The other difference is the latency. The latency for injury is very short. It could be milliseconds because it occurs, the acute transfer of damage to the human body occurs instantly. On the other hand, the latency of disease ranges from hours to days to weeks to years, depends on the specific disease. This has some, I guess, very important implication for prevention. Because of the very short latency of injury, say screening and those kind of traditional clinical approach to disease detection and prevention may not necessarily apply to injury prevention. And the other major difference between injury and disease is the potentiality or intent. Injury, as I mentioned early on, could be divided into unintentional injury and intentional injury. So there is an intent dimension involved. On the other hand, disease, I would say rarely you have anyone who intentionally get a disease. So virtually you can categorize disease as all the disease as unintentional. Preventability, in general, injury is preventable and there is a high preventability. On the other hand, disease could be prevented for some of them, but for some others, like cancer and diabetes and other chronic diseases, they are preventable, but they are very difficult. It's much harder to prevent those diseases than injuries. Susceptibility, nobody is immune to injury. There is no vaccines for injuries. So the susceptibility to injury is universal. Everyone is susceptible to injury. And if you have sustained injury, you are not immune to avoid next time. You are still susceptible to be injured. On the other hand, the susceptibility to diseases depends on the type of disease. And for a lot of infectious diseases, nowadays we have very effective vaccines, and that provide sometimes lifetime immunity. The medical approach, I think this is also very important to identify the differences between the two. In medicine, the approach to injury is the emergency medical services, including pre-hospital care, emergency care, and ambulance and 911 response system, and so on. And also in the hospital, you have the trauma care units, a burn unit, and so on. And also rehabilitation medicine serves a lot of the post-trauma care to help recover some of the functions. On the other hand, in disease prevention, the medical approach usually involves screening, early detection, early diagnosis, and treatment. So that table shows the differences between injury and disease. On the other hand, injury and disease are interrelated very closely, and there is an ever-growing body of literature documenting the complex dynamics between injury and disease. Again, this relationship is bidirectional. And I listed some examples here, like traumatic brain injury could increase risk of Parkinson's disease and many other neurodegenerative diseases. On the other hand, dementia could increase the risk of falls. there are many other sort of examples you can tell, like depression, increased risk of suicide as sort of a disease and injury relationship. The other concept I would like to introduce here is accident versus injury, because the term accident still being used in some parts of the world, especially in the public health and medicine field. So what are the differences? I listed a few here. In terms of the definition, accident refers to the event that may or may not cause human injury, okay? It could be a major accident that may not involve any injury. In that kind of case, the accident itself is not a public health problem because it doesn't cause any damage to human health. On the other hand, the injury refers to the health consequences of the event. If you want to use the term accident, nowadays we try to avoid the term accident. Instead, we say crash or shooting or incident. So injury refers to the human health consequence of the event. The overlap between the two, as I mentioned, accidents does not necessarily result in injury. Sometimes the accidents do. On the other hand, injuries are not necessarily due to accidents because, as I mentioned, say self-harm is intentional and it's not an accident. So they are not the same. There is an overlap, but not the same. More importantly, the connotation of the two terms are, I think, what the public health and medical professionals are concerned about and why they would like to avoid using the term of accident. Because accident traditionally implies the event is sort of it's not preventable, avoidable. There is this here under notation. So there is no accident. That has been sort of mantra in the past 3 decades in the field in injury prevention. And there have some substantive changes to avoid the term accident. Say the National Safety Council in the United States is the oldest non-government organization specializing in safety. The National Safety Council publishes annual report. It's called, used to be called Accident Facts. Say every year there is a book documenting in excruciating details on the accidents in the United States. They started in 1921 and until 1998, the annual report book is called Accident Facts. Okay. Then in 1999 and now on, the title of this book, the publication, has changed to Injury Facts. And in 1999, when the title was changed the first time, there was an explanation in the book. I listed here, say the change in title to foster a change act. Some to fit that or unavoidable. Research has shown, however, that injuries result from hazardous conditions can be corrected and unsafe behaviors which can be changed. For several years now, the National Safety Council has been curtailing use of the word accident whenever possible, so as to reinforce the message that injuries can be prevented. So in the past 22 years, the annual publication of the National Safety Council has been called Injury Facts. And I thought this explanation is very clear and very insightful. On the government side, the National Highway Traffic Safety Administration, which is a functional agency of the Department of Transportation, has been gathering data on fatal motor crashes since 1975. So every fatal crash that occurs in the United States in the public roads is investigated and is recorded in a database used to be called Fatal Accident Reporting System. So it's called, in short, as FASS. Under this, the FASS system has been used for research and policy under safety standards and so on for decades, since 1975 to 1998. Again, in 1999, the federal government agency decided to avoid the term accident in its data system, the FAST data system. So they changed the data system name to Fatality Analysis Reporting System. It's still FAST in terms of acronym, it's the same, but fatal accident, the accident now is no longer in the data system. It's called Fatality Analysis Reporting System. I have not been to Guyana yet, but I was curious yesterday when I was preparing for this talk. Here on the left side of the screen is the front gate of the Columbia Medical Center. Here you see the emergency, and this is the sign for emergency department. And if you go to a different hospital, usually it's emergency or emergency department. On the other hand, I know in European countries and many other places, we still have this term basically called accident and emergency department. And this is Georgetown Public Hospital sign. And decades ago, in most of the hospitals in the United States, accident and emergency was used as the name for the emergency department. But the change has occurred for about half a century. In terms of the magnitude of injury as a public health problem, this is the message I would like to, the simple message I would like you to say I would give. In general, injury is the #1 cause of death for children age 1 and up to young adults up to 44 years. So in this age range, 1 to 44, that's pretty much the first half of life span. Injury is the #1 cause of death. For children, especially say those teenagers under 21 years old, actually injuries account for majority of total mortality. And this is CDC data for the United States. For children ages 1 to 9, injuries account for 39% of the total mortality. And for those aged 10 to 24 years, almost 3/4 of the mortality resulting from injury. And even for the young adults, injury alone causes half of the total mortality. So that's why the injury is leading cause of death for people ages 1 to 44. And this is not unique to the United States. It's the same case in world industrial countries and increasingly in many developing countries. If you look at the data like this, they are very similar. So this statement is generally true. And if you break down by the leading cause of death and by age groups in more details, you can say for those, this is United States data, and unintentional injury is the #1 cause of death for people age 1 through 44. And the #2 cause of death, you can say for teenagers, young adults, suicide is #2. And here we're talking about intentional, a type of intentional injury. And homicide also is a third cause of death in itself among adolescents and young adults. So I did check the Guyana data. You do have pretty good injury surveillance data. This is from the Global Burden of Disease Project, a pretty recent data, 2019. And I look at the top 10 causes of death and disability in Guyana. And you can say the top 4 are diseases, like heart disease, diabetes, stroke, and neonatal disorder. That usually refers to congenital disease and other type of neonatal disorders. That would be the sort of the leading cause of infant mortality. And then you look at the individual injuries. 3 of them occurred on the top 10 causes in Guyana. Self-harm, interpersonal violence, that's basically sort of assaultive and homicide injuries, violence, and then traffic injuries. And if you put injuries together, and I think you may say very similar pattern as what I shown in the United States data. I'll skip this one. This is the death rates from suicide and homicide by age. And the age distribution of intentional injuries, of the 2 forms of intentional injuries, are quite unique. And it's like a signature. And especially the homicide, the death rates, the age distribution, as you say, it peaks in young adults, and that refer to premature death, and those injury deaths usually have a much greater impact on the life expectancy of the population. Prevention strategy. This is the standard epidemiological model. It's called epidemiological triad. Anyway, under this model, any health problem, disease, or injury is the consequence of the interface of 3 factors: the human host, the etiological agent, and the environment. So in the past 4 decades, injury prevention has been really guided by this so-called Hayden matrix. Hayden matrix is named after the work of Dr. Bill Hayden. Dr. Bill Hayden was a public health physician and was used to be working at the New York State Health Department. Then he moved to DC and was the founding administrator of National Highway Traffic Safety Administration, and has been widely viewed as the founding father of injury epidemiology and prevention. And the Hayden matrix basically is a 3x3 sort of matrix, and the role dimension here as the three elements of the epidemiological triad: host, agent, environment. And then what he did to the standard epidemiological model was that he added a time dimension, and he categorized the time to three categories as well. So pre-injury, injury, and post-injury. And this has served as a conceptual model for brainstorming or for developing prevention strategies for specific injuries. An example of, say, the Hayden matrix being used to identify strategies to prevent motor vehicle or road trauma. As you can see, almost every cell in this matrix could add a different sort of a prevention strategy. And like at the crash stage, the crash worthiness and protective roadside objects and so on, those have between environment and crash have been sort of major intervention in highway traffic, highway transportation engineering. And in road design and road layout, speed limits, and the pedestrian facilities and so on, those basically are the, that's the pre-crash environment, and has also made a difference in bringing down the morbidity and mortality from motor vehicle crashes. What did Dr. Bill Hayden did is that, as I mentioned, he made the static epidemiological model into a dynamic model by adding that time dimension. And this is my sort of graphical interpretation of Bill Hayden, the Hayden matrix. So you have pre-injury, injury, and post-injury in this standard epidemiological model. And during the pre-injury phase, you're dealing with exposure to injury. At injury phase, you are dealing with the risk of injury given exposure. And post-injury phase, you're really dealing with the case fatality ratio rate. And there is a mathematical foundation to that, to the Bill Hayden matrix. For medical conditions with a very short latency, such as injury, there is this simple mathematical relationship between death rate and the three elements. So death rate basically is the product of case fatality, incidence density, and exposure prevalence. What does that mean? So that simple equation implies there are three approaches to injury prevention. Number one, you could reduce exposure to injury. And number two, you could reduce the incidence density given exposure. And finally, you can reduce case fatality after injury through, say, improved EMS system, trauma care, rehabilitation, and so on. And this is example of the approaches applied to the current opiate epidemic in the United States. I listed some of the actual interventions under each of the three approaches, such as reducing exposure to this particular type of injury, opiate overdose. You have the prescription drug monitoring programs and physician training, and prescribing guidelines, alternative treatment, public awareness, and so on. And the maiden matrix, the Hayden matrix, has been applied to at least 40 different types of injuries in the literature. You can, if you look do the literature search, here is an example of the Hayden matrix applied to occupational injury prevention. And this one is an application to preventing violence in the workplace using the Hayden matrix. Interestingly, I couldn't find an application of the Hayden matrix to suicide prevention. And I would like to point out in the Hayden matrix, environment is not limited to physical environment. Actually, environment refers to both the natural environment or physical environment and the socio-economic environment. And I think that might be the reason why that, say, suicide is among the most researched or studied health problem. But on the other hand, if you look at the statistics, it's the least prevented or improved health problem. And it seems the enormous amount of research on suicide has not been successfully or effectively translated into successful prevention programs. But there are very successful stories in the past 2 or 3 decades, and in suicide prevention. I would say one of the most successful program in suicide prevention occurred in China in the past 2 decades or 3 decades. Before 1990s, China had the highest suicide rates, especially among young women in the rural areas. And the majority of those suicide deaths involved the injection of pesticides. Pesticides were at that time, say, not widely distributed and not restricted at all. Every household could have some bottles of pesticides because they use individually and was not stored safely. So there was no restriction to access. And then when there was a crisis for anyone, they just go to ingest the pesticide and die. And it's a painful death, but it was really widespread. And that was, so each year in China in the 1980s and before, every year there were about 750,000 deaths, or 3/4 suicide deaths. And it was among the highest suicide rates in the world. But starting in the early 1990s, the government started to change the policy. They did not allow the distribution of pesticides to individual households. Rather, in every village, pesticides have to be stored in one place that is sort of locked up and as the safety cabinet, and it's locked. Unless you need to use it and get approval, you can get the pesticide. And so individuals would not have the access to this poisoning to commit suicide by ingesting it. And the change has been dramatic. So since the 1990s, suicide rates in China has decreased by almost 80%. as you can see from this in both males and females. I would say the restriction to the pesticides made a major additional contribution to this remarkable reduction in suicide mortality in China. The other one is getting a lot of attention, but addresses a relatively small portion of suicide, which is, say, jumping from bridges and high buildings. This is the George Washington Bridge over the Hudson River. On the east coast of the United States, George Washington Bridge used to be one of the most popular places for people to commit suicide. They just simply jump from the bridge to the river, and the case fatality is virtually 100%. Each year, there were a dozen or so fatalities involved. And on the western coast was the Golden Bridge, Gate Bridge. That sort of also attracted a lot of people to commit suicide by jumping from the bridge there. And fortunately, about 3 years ago, both the Golden Gate Bridge and the George Washington Bridge, authorities decided to address this problem differently. Instead of using those crisis phone calls and patrols and so on, they decided to add some safety nets and fences. And this is George Washington Bridge. This is before 2018. And as you can see, the sidewalks on the bridge for pedestrians had just the guardrails, and it's not that high. It's very easy just to jump from the bridge to the river. And now you can say it's impossible to do that because we have just installed the fences and the safety lights, and it's much safer now walking on the bridge. And since then, this restriction or modification to the environment, we call it means restriction, has virtually eliminated suicide by jumping from bridges. I'll basically stop here, but this is two more simple slides. At Columbia, the Mailman School of Public Health the dean would administer the public health oath to incoming students, and also the same oath would be administered at commencement to those graduates. So twice for any student coming through this, the Mailman School of Public Health, they would be administered the public health oath at the beginning of their study and then at the time of their graduation. So the opening remark of race, I will work to ensure that people have the chance to live full and productive lives, free from avoidable disease and disability, and supported in their pursuit of physical, mental, and social well-being. So that was the opening remark of the public health oath. So what's missing here? When I joined the school, I realized that there's something missing. What's missing is injury, because you're talking about disease and disability, and ignited the leading cause of death for children and young adults, which is injury. So I went to the dean and asked her to add the one word, injury, to the public health oath. Unfortunately, she accepted my recommendation and made the change. So ever since 2012, the public health oath at the Mailman School of Public Health has the word injury here, free from avoidable disease, injury, and disability. I feel that might be my most important accomplishment in the past decade. Thank you very much. I'll stop here.
Dr. Li, thank you so much for this talk. I think it's really important for students and practitioners to really become more aware of the Hayden matrix and how it can really be applied to not just injury and different types of injuries, but to public health in general, any problem. When it comes to suicide and self-injury, in possibly avoidable, fatalities, it is important to consider both the physical environment, as you described some of these important public health campaigns, like, protecting the bridges, locking up the chemicals, but also to think through some of the social aspects, not only related to reducing exposure, but also incidence and fatality. But I just hope part of this, the GRITT training program will really have people and students become more, and practitioners become more aware about the Hayden matrix and really almost brainstorming of how to fill in those boxes.
I agree. It has been used, at least started being used to address some non-injury issues. And that was a paper maybe 2 or 3 years ago, in which the authors used the Hayden matrix to stretch as prevention strategies for some environmental health issues. So not injury at all, but they felt the Hayden matrix is a very important tool to develop prevention strategies. I agree with
provides a framework for different people with different strengths and objectives to come together on a common goal, I think.
Exactly. It serves as conceptual framework. Yeah.
Well, we really appreciate you talking to us. I don't know, are there other questions from other participants? Well, thank you for getting up early on the East Coast to talk to us.
Thank you. Okay, no problem. My pleasure.